Okay, folks, if you'll take your seats. All right. So what we're going to do is, obviously, I've asked the impossible of all you folks in the last hour, but particularly the moderators who are trying to summarize these things. And Rich Prelip and the group on drug safety got theirs going early, thank God. Thank you, guys. And so I'm going to bring Rich up, present these. We're going to have some question answers if anybody would like to after Rich makes his presentation. And then by that time, the others will be back, and we'll just kind of keep rolling forward by that time. Okay, Rich?
Thank you, Mark. And we were the drug safety group and had a lot of lively discussion and interesting interaction, and tried to maintain the focus of coming up with discrete, identifiable recommendations for APSF and by extension to our anesthesia providers in general. So as you can see, here's our 4 recommendations. I'll just go through these. APSF will join with other organizations to assess or reassess the risk-benefit ratio of nitrous oxide and educate providers of our findings. Number 2, APSF endorses multimodal programs for postoperative analgesia and similarly endorses continuous monitoring of oxygenation and/or ventilation parameters for all patients requiring opioids. Again, somewhat just restating and reinforcing a previously stated principle of APSF. Number 3, APSF will collaborate with the FDA to understand hepatic toxicity of volatile anesthetics. We were fortunate to have Ray Brown in our group, and he said these sort of very specific, identifiable potential concerns in a post-marketing arena, obviously for drugs like desflurane and sevoflurane, are things that the FDA actually will pay attention to and could find appropriate response to these kind of efforts. And number 4, APSF will convene a task force with other to be identified organizations and individuals to identify novel and safer anesthetics, at least for us here in the United States, including such things as xenon, medium chain triglyceride propofol, a formulation felt to be safer and free of the PRIS infusion syndrome, and even other anesthetics, with the idea, kind of the generalized principle, that the U.S. in many ways has sort of been a follower and not necessarily a leader in innovating and adoption of new anesthetics. Those are our 4, and I'll be happy to entertain any comments or questions. Hearing none, we'll move.
I'm going to start the questions because I know who ends up holding that bag back at home. First of all, Rich, on the number 4, and I'm not trying to wordsmith, I just want to make sure I understand. APSF will convene a task force to advocate for novel and safer anesthetics, or I don't think we're going to identify them, are we? I mean, you understand the distinction here? I want to make sure I get the right wording.
Yeah, I think we got to wordsmith some of this. I think it's to identify the most promising agents, work with industry to help see the advantages to the anesthesia patient community complex, and then to advocate for those new drugs.
Okay, and then, am I the only one with a question? So number 2, when it gets to continuous monitoring of oxygenation and or ventilation parameters, did you mean and or are we more aggressive in saying and?
We sort of left that as in the terminology which gives various institutions and individuals the maximum flexibility, recognizing obviously the capital acquisition costs of continuous capnography monitoring, but also recognizing that it was the consensus of the group that there is an independent value of continuous oxygen saturation monitoring. It obviously doesn't identify all cases of respiratory depression, but it still can be a valuable adjunct. So probably the two together is the optimal, but leaving maximum flexibility for adoption to various institutions. It looks like we now have a question.
And I'm just going to add, the reason I ask is because I think if APSF through ASA had not put in standard guidelines to require intraoperative pulse oximetry, who did I just talk to about this at the break? Was it Steve? Yeah. We wouldn't necessarily be doing it yet. Yeah. There'd be people individually who would decide not to use pulse oximetry. I personally think, God, we ought to require it. But Steve, what do you think?
And yet, as somebody pointed out, there is still no outcome study that shows that pulse oximetry helps patient outcomes in the operating room. So, let's throw it away, right? Mark, I just want to point out my quota for yakking starts over today because this is a new format, right?
It's only allowed to be a curmudgeon through most of yesterday.
I'm back to number one curmudgeon. Great idea. I wonder if you thought about, at some point, APSF in general, expanding this, because a lot of these DIB, dead in bed cases, happen after the patient goes home and they're taking oral opioids. And I don't know what the answer is, but now with iPhones and Bluetooth and everything, post-op monitoring could continue at home on patients that are taking opioids. And like I said, a lot of DIBs happen there.
I think that's a great idea, and certainly one worth sort of endorsing and collaborating into this. I guess it's our number two concept
Right.
here.
Yeah, let's talk about it.
Yeah.
That's something we'll solve today.
Yeah.
Barry Metz, Penn State. I am dismayed that we don't have and. I think it's crucial that we send a very, very strong message to all our administrators and leave no weasel room at all. Because I think we have to have a further measure of ventilation than just pulse oximetry. As we know, it's delayed in delayed in establishing respiratory depression. I'm completely dismayed, and I don't think we should allow anybody weasel room. And so I would suggest amending it to remove the or and just have oxygenation and ventilation parameters for all patients receiving intravenous opioids.
In partial answer to that question, I'd like to just get a show of hands for those individuals who work at institutions who now in place have continuous capnography or CO2 or respiratory monitoring for all post-op surgical patients receiving opioids in the hospital.
0.
I believe I see one hand. Two.
We have it for PCAs, but
For PCAs,
Yeah.
and OSA. He has PCAs.
Well, what about neuraxial opioid?
Yes.
Yeah.
But you're quantifying it.
Yeah,
basically.
you're right. All right. But I think that was the reason for the or, is just a recognition of reality. Though in my heart, I agree 100% with the mandate that that's exactly where we need to be, and perhaps Jenny will add to that thought.
So two disclosures. One is I'm a surgeon, which negates a lot of things. The other is that I also run a company that does minute ventilation monitoring. I would like to go 2 steps beyond the previous discussant and say 2 things. Most patients on the hospital floor do not have a primary problem with oxygenation, it's with ventilation. And I think that the problem with us trying to do pulse oximetry monitoring, which I've done for years as a surgeon, baby heart surgery, and is that there's so many false alarms that nobody pays attention. So if you actually monitor ventilation in a meaningful way, and I don't think capnography does that because of false alarms again, and we can talk about that ad infinitum, but in an on the floor setting, if you monitor ventilation well without false alarms, then you can monitor oxygenation sporadically, either at the standard 4-hour times, or when your ventilation drops, and maintain patient safety. Ventilation drops clearly well in advance of oxygenation. Some of our data from Mass General is 71 minutes. In some settings, it's less, but it's a long time that you drop your minute ventilation before you drop your oxygenation. So there's plenty of time to go in and actually assess the patient, check the oxygenation, change the care plan, and really impact the care. So I think that that's true, and that's one point that I would go in, further than our previous conversation. The other one is that what we've seen lately is that everybody thinks that you're making people safer by going from IV to oral opioids. But what we've seen with our monitor, and probably with other people if they've looked at it, is that actually there's much more variability with oral opioids. And so, if you've got somebody that's got a gastric bypass that has just gotten to a Percocet, we've seen patients that have been fine on fentanyl and the PACU. They get their first dose of 2 Percocets and they go way down. And I think that we assume that the pharmacokinetics of these oral opioids are based on traditional data from volunteers or patients that have pain issues that are not initially in the post-operative period. So in post-op, sometimes there's more absorption if you've been operating in that area, and there's more absorption. I mean, I'm not a pharmacologist. You guys can slam this, but the other bit is sometimes you've got gastroparesis and it doesn't get absorbed right away, so you give another dose and then it all kicks in at once. Or if it's an obese patient that has OSA that you're worried about anyway, you don't know. So I think that it's really important that as the community is starting to perceive that oral opioids are safer than IV opioids, I don't think so. I think we're going to go way over the wrong side of the spectrum, and we're going to find out 3 years from now that IV opioids were, on a PCA, were way more safe than oral opioids, but, that's just a prediction. Thank you.
Yeah. Interesting comment. Thank you. Yeah.
Jenny, if you just put a $20 pulse oximeter on your monitor, you wouldn't have had that whole discussion. You could actually advocate for both.
But I wouldn't run it all the time. I'd only run it when the
Okay,
ventilation
well,
is down.
So respiratory motion only does ventilation.
Unless you had children that you're taking care of.
To Dr. Metz's point, there are places that have implemented capnography and have let go of their oximetry because they liked the ventilation monitor better. There's reasons for that. So in 2011, we went through we had the and or discussion for a prolonged period of time. 2006, we said everybody must have oximetry. And then in 2011, we changed it. There were a lot of reasons for that. I don't want to go into that, but there are organizations who capnography is climbing Mount Everest in terms of implementation. Oximetry is climbing Mount Hood, Mount Rainier or something. It's much easier to do. We only have about 20 or 30% adoption. Let's get those other 100% on board, and then we force the rest of the issue. But let's keep pounding on those people. Let's get a broader base and not get into this minutia. That's just my recommendation.
So are you endorsing the and or language, or you want it to be just and, or?
I made you put the and or in there. We had and ventilation.
Okay.
And I think climbing Everest and Hood all in the same week is too much. Let people choose. If they bring in ventilation, fabulous. There's good ventilation monitors. And oximetry is the easier way to go. It'll make patients safer instantaneously.
I think it'll be a critical point for the final wording of these recommendations when they come out, is to nail down that construct. Yeah.
Tim Dowd, recently Mednax. I think that you really want to change the thought process here and sort of go with where the politics is in the United States right now. I would say you shouldn't use opiates in your hospital unless you have available pulse oximetry because it's unsafe. And it's a way of controlling the use of narcotics. It is very current with what the country, where the country wants to be. And I actually think it's the safer approach. So a hospital that says we can't afford to have pulse oximetry on the floor because we can't afford the equipment or we can't afford somebody to actually look at the pulse oximeter, fine. What you just said is you can't afford to be giving narcotics to your patients in the hospital. And I think it's a different way of looking at it, but I think it's a interesting way to look at it, and I recommend that to you.
Great thought, and I think they'll be vetted further as we kind of refine these recommendations. Thank you.
Okay, good. Thank you, Rich. Okay, what else do you have back there in the back that we can use? Which group do you have on tap? Sure, Jenny.
In keeping with that, there's plenty of patients that do go home. So if you make that kind of a mandate just for patients that stay in the hospital, you're kind of losing it. So if you actually can help risk stratify those patients in terms of opioid sensitivity while they're in the hospital in the recovery room, I mean, there's plenty of patients that are in outpatient surgery still and will be over time that are going to go home on oral opioids. And again, if you kind of figure out how to risk stratify them either genetically or by measurements of ventilation in the PACU after opioids, you'll do a better job of when they go home instead of just mandating the hospital. It's the whole care package. Thank you.
Thank you, Jenny. We're going to have to keep playing with this a little bit, but I really encourage you to be aggressive. We can always scale things back, but let's be aggressive up front if you think it's justified. Steve? Which group was it?
This is the drug shortage recommendations group, and I want to thank Mark for including all of us. I also want to thank our very active, animated group. I think there was a lot of contribution among our little 16-person group. I put this slide up first before the recommendations because this is sort of how we began our session, and that is just to remind everybody how complex drug supply is to us for us as providers, and then finally as patients. Look how complex this problem is. And so from that, we actually, both Dr. Cohn and I, put together about 10 possible solutions, and our group added another 10 to that group. So within an hour, we took 20 potential solutions and we scaled them down to 5 based on significant 2 or 3 rounds of voting. So we voted, and then we came up with the top 5 based on voting. So we had 16 people. So I just wanted to give you our process of how we scaled this whole situation down. So now we can go back to the recommendation slide. And back to the drug shortage recommendation slide. There we go. Okay. So again, the numbers indicate how many people in our little small group, actually voted for these. So the first one was APSF website provides key drug shortage information to providers coordinating with other national organizations. A multidisciplinary provider group should be establishing criteria for using specific products for their indicated use. So 13 out of 16 of us said that was a good idea. Number 2, support other organizations to consolidate concentrations of commonly used drugs. And all of us, this is a unanimous point to make. The third was manufacturer/supplier report card for quality. That is standardize or help support developing a standardized report card for manufacturers, suppliers that would require them to use in order to continue on with production of a particular product. And about 50% of us voted for that. Number 4 was manufacturers and GPOs sharing risk with the hospitals, so get them to share the risks in terms of quality and stockpiles as part of the initial contract that hospitals actually sign off on. So share the risk among all the components of drug shortages or drug supply. About 50% of us voted that one in. And then lastly, FDA should require manufacturers to have contingency plans, and some of this is already being developed, for drug shortage excess capacity in stock. And again, about 50% of us agreed with that statement. So this was 50% or greater, and then again, like I said, we took about 15 others that we have in our backup supply and took those out of the top recommendation list. So I'm happy to field any questions that you have about our process or about some of the suggestions. Remind you, we ran out of time actually, and a lot of these need some wordsmithing, particularly as they relate to how the APSF will be able to make some of these things happen, or at least support them in a different fashion. But again, this is a starting point. Questions? Okay. All right. No problem.
Well, just a couple questions. Again, it's how it gets done. APSS has 2 staff members, Stacy Maxwell and me. I'm kind of curious as how some of these things get actually done. So obviously, when I talked about we're going to bring a work group into Chicago to figure out how this actually gets done, because practically, Erin Fox spends her whole career doing number 1. So would we replicate? We wouldn't replicate. We'd obviously link and tie and form relationships with people to do that. So it's all very interesting. APSF is just a tiny thing. We don't have members or anything. So I'm just saying we have to form relationships with others. And I think that's what you were saying. We need our professional organizations. We need our regulatory agencies. We need Ray Brown and the FDA groups to help figure out how this actually happens. Because if it was simple, these would have all been done already. We need to be the convener, I think, to pull people together. Is that correct?
That's absolutely correct, Mark. And actually, we talked about the first one, sort of taking from other websites or sharing information with other websites and making it anesthesia or perioperative specific on our own website, so that it would be high-value information for our providers. So that's sort of what a lot of these have to do with, really scaling down all the information out there and becoming a hub at the APSF for information exchange for those providers that are interested, all of you out there. So
an example on number 1 might be we might work with Aaron, Deb, others to figure out how could you make a perioperative shortage thing. Okay, good. Yeah. Oh, that's very helpful. Any other questions for Steve? These are all simple things. Shannon, you need to get to a mic. Can you do it?
I would say with number 1, I totally understand the concept, but that you have to watch what you publish from hospital to hospital, because different hospitals have different purchasing agreements. And we ran into a problem in our hospital with the advanced practice nursing group sending emails about what they wanted to have their nurses using, which was exactly contradictory to what we wanted our anesthesia providers doing. So I just wanted to share that and make sure that you understand that that might not be every facility. So maybe a little disclaimer would be important.
Excellent point. You're talking about the second part of the number 1, correct?
Yeah. No, the first part. I mean, there are drug shortages everywhere, but what's short at my hospital,
may be different.
Somewhere.
Absolutely. Absolutely. Nice point.
Just a quick comment about.
Lift the mic up so they can get it. Thank you.
Okay. Didn't realize I've grown taller, but. Quick comment about number 3. I think this is something which is very important. There are already scorecards for everyone. I'm kind of surprised it got 8 votes. But this is something that APSF can work with other organizations from advocacy point of view. And this will bring about more transparency. There are different manufacturers. Sometimes there are small manufacturers, large manufacturers. While we're negotiating these contracts, this will also give us the leverage to make sure that we are having the right contracts and being cost effective.
I think that's
I appreciate
great.
This has been brought up, but this is something which we can focus more on.
It's a great point, and actually in our group, 2 of the industry members that contributed a lot actually brought this up. So it's coming from the industry side. People want accountability. So I think that's something we absolutely should pursue through our organization, national organization.
And just a quick comment on number one, because I'm actually a pharmacist, but I also work with anesthesia, and I've seen pharmacists really struggle with your drugs in terms of how I think it would really, really help with either whether it be the ASA, or I know SOAP did that with the shortage on spinal bupivacaine, for strategies to help partner and how to ration the current supply that we had, because I can tell you pharmacists don't know. And I've also seen some of the things come out with Vizient, and the recommendations were not, they really could use your help with how to ration, for example, local anesthetics or drugs specific for you within anesthesia, within surgery. That would be extremely helpful to take back to your own institution to use it.
Great point. And in one of our, and you were in our group, one of the topics that didn't make the cutoff here, but we still have, was developing a team that would address that within your hospital system. So that may be something to readdress as we move forward. So thank you for your comment. Thanks, Mike.
Thank you, Steve.
Yep.
Okay, great. Thanks, Steve. Yeah, you can see all these. You could take any one of these and you could write 3 articles for the newsletter. We can put teams together. Every one of these is a huge amount of effort, but that's fine. It's the right thing to do. We've got leaders from AANA here. We've got key leaders from ASA here. We got the professional groups represented. We've got great pharmaceutical and pharmacy supporters here. So I think our role is to be the nidus or convener, kind of the apolitical group, apolitical in any sense you want to use, to pull people together. And I think that's probably what our major role is. Megan, you're next? Okay. Reducing medication administrative errors. Y'all have that back there? Oh, it's already out. Okay. Thanks, Megan.
All right, good morning, everybody. I have to thank Lynn, my co-facilitator, and our lively group for a great discussion on reducing medication and administration errors. We were not able to get it down to 4. That did not happen. I want to assure the members of the group that we have more detailed notes that we're going to give to Mark and Stacy, so all of the comments that were made are going to get into those notes. But basically, we broke down our recommendations into 5 different areas. I've bolded the ones, I've taken the liberty of bolding the ones that seem to really percolate to the top as being of special importance. So we said that the APSF should endorse prefilled sealed syringes, that is a safer way to deliver medications, and that maybe even on the website there would be a resource for organizations that had struggled to implement them so that we can help people make the business case, for instance, to their organizations about why it's a good idea. We talked about the importance of standardizing the anesthesia cart, the surface, our workspace, and even our trays, and maybe thinking about what are the drugs that we use most commonly, and should there be some level of standardization of what's in the top of our carts. We talked about keeping in mind that recommendations should cross facility size and type. So we have large institutions, smaller institution, groups that have EMRs, groups that don't. And so whatever recommendations we come up with have to account for variability in the ways that we practice. We talked about maybe even thinking of changing workflow, because a lot of what we do now is give a med and then document. But for some of the safety solutions that may involve barcodes or RFID or something like that, they can only help us if we do that before we give the drug. And so maybe we should think about changing our workflow so that we document first and then give the drug, so that our clinical decision support systems have the opportunity to help us. From a technology standpoint, we thought it was important that the APSF advocate that technology should talk to EMR. So whether it's Epic or Cerner, whether it's a smart pump, that all of our pieces of technology should be able to interface with each other, again, for the idea of being able to use that as a check on safety. For advocacy and education, we thought it was important that the APSF maintain a relationship with the EMR vendors and try to have a seat at the table, especially as some of these vendors create sort of foundational platforms. So Epic, we talked about how Epic looks different in lots of different institutions, but Epic is now interested in creating a foundational Epic that looks more standard across institutions, and so we'd want to have a seat at the table as they do that. We talked about accountability and responsibility at the individual provider level. So we did focus on systems level solutions, but one of our members did bring up the idea that even at the individual level, there are things that we can do to try to make medication safer. For research and quality, definition was actually probably the most important thing. What is a medical error? What's the taxonomy of medical errors? And related to that, how do we prioritize those? So some of those errors are going to be more important than others. We talked about the importance of just culture, creating a space where people can actually talk about errors that have been made without fear of retribution, collaborative solutions, so making sure that we do multidisciplinary work, metrics so that we know that a change is an improvement, a national patient safety sort of reporting system that could be errors or just some system for us to report errors and near misses. And then clearly we need a work group. So maybe the work group could come up with a 3-year strategy, what needs to happen right now, what could happen in a year, 2 years, 3 years. And in that work group, people that are involved with APSF, but also we'd want the EMR vendors at the table there too. And that's probably incomplete because we'd want tech companies involved in that too. So it's a lot, but it's a big topic. So happy to entertain questions or if there are members of the group who want to expand on something that we talked about. Yeah, right.
Mark, do you want to say something first? Or?
Everything's by invitation. You just get up and do it.
Okay. Deb Pasco from ASHP. So, of course, my medication safety officer and me can't help but get up and say something. So, first of all, this is a great list. I think it's pretty comprehensive. I like the categories and how you've divided it. Under technology, I would also add one little caveat. Because there are technologies now that have this, about adopting technology solutions that can eliminate the need to do math calculations for drug administration. So I know all of us in this room can operate a calculator. We do it quite well and we're very proficient. However, we shouldn't have to. That's not to say don't teach that, but bottom line, we have technologies that can do this for us.
Thank you for adding that. Rich? Yes. Yes, absolutely.
Thank you, Megan. One topic that our group touched on, but we thought it would probably fall under your category, was the issue of the sterile administration of drugs to patients. And I think Andy highlighted that in his brief presentation yesterday with the alcohol impregnated caps on stopcocks, provider recognition that vials do not come with sterility on the rubber stopper, and that needs to be addressed when you draw up medications out of those vials. And I don't know where this falls into, if it's in your section or not, but I'd like to see that incorporated at some level in our final recommendation.
That makes sense, and I think that falls into practice. The pre-filled, the sealed part of the syringes, that part of that was to address the issue with sterility, but clearly still when you administer, if your stopcocks aren't covered, there can be issues with contamination. So thank you for adding that.
I just wanted to make a comment on the research and quality section. So I do think we should put in some effort, whether it's around advocacy or working with other partners, around defining some metrics. Because if we are not measuring it, we are not reporting it, it doesn't exist. So first of all, we as a group have identified this as a problem, but we truly need to start measuring it and reporting it. Otherwise, it remains something that is non-actionable.
Thank you for adding that. It reinforces some points that we made. We do need to figure out what exactly an error is, what we call it, and how to measure it. So thank you.
Right. I would second that. And I think one of the things we should all do is collaborate in sharing errors throughout maybe the foundation, so we look at commonality of errors that occur. I know at Michigan we have a specific group that is just focused pharmacy anesthesia on looking at medication errors and doing root cause analyses of all these, and have made significant process changes based on really taking a deep dive. And I think if everybody collaborated across the country, we would learn that there are probably a lot of common themes, right, that we could all work on.
Absolutely. And one of the ideas that came up in the session was actually an interinstitutional exchange, such that people might go from one institution to another and just sort of watch and say, oh, this is interesting that you do that. Let's talk about ways to do that differently, or maybe we should take that home. Tim?
Oh, I was just going to suggest you might add to this really focusing on reporting errors. Because when I talked to ISMP, they said, we rarely hear about any kind of errors from anesthesia. And so one of the thoughts would be to focus more on, maybe in the newsletter or whatever, how to report these errors so that you begin to build a better understanding of where the errors are occurring.
I think that speaks to our ability to measure what's actually happening, and that's why we emphasize the just culture, because there was a concern that people feel like it's really not safe to report.
Yeah, and I just wanted to address your top thing, prefilled syringes. When I was at AstraZeneca, we tried for over 10 years to get prefilled syringes on the market. And it's such a conundrum because it's a joint, it requires the technology group that knows the pumps and the drug group that knows what's inside the prefilled syringes to agree, and they never agree. It's like ping pong. What's the status? Oh, we shot it back over, and no, we shot it back over, and so it's a difficult challenge, and just be aware that if you're going to advocate for this, you really have to have a pretty smart program that recognizes all the hurdles, because not all syringes have the internal diameter that will deliver a known amount if the internal diameter isn't a regular size of a 20 cc syringe or a 50 cc syringe. So I laud your efforts. I think they're needed, but it's a big challenge.
Agreed. And if I can interject one thing, I think to Jan's point earlier, there are some implementation challenges related to clinicians and uptake and trust that need to be addressed as well that I think we don't fully understand. But thank you, everybody, for your comments.
Okay, and Jeff Feldman is going to report out on the Standardization Innovation Group.
So we had a lively discussion, and I just want to recognize Patty Riley and Tim Vanderveen, the co-facilitators, and the rest of the group. What was really nice about the group was the representation. So we had industry, we had a variety of different clinicians, we had pharmacists. So it was really great for the amount of different types of input that we benefited from. And I actually have 3 volunteers already for work groups, Mark. So there were 3 categories of topic that we were tasked to talk about. One was concentrations. And so the first bullet point is our primary recommendation, and that is that APSF should promote nationwide consensus on standardized concentrations of medications for syringe and infusion administration. And this was really something that we came to consensus on pretty quickly. And I think one of the interesting benefits that was articulated from the industry providers is that will be a way to actually begin to address the drug shortage problem, because the amount of different types of things you'd have to prepare would be much smaller. You could have a much leaner manufacturing process. So it would have benefits for drug shortages, cost as well. So they actually really welcomed that kind of guidance. And part of that clearly is to build consensus with a lot of the other organizations already working on the topic. So there's a lot of work out there to build on and try to bring those groups together. One important bullet point, sub-bullet point to this that came out of our conversations was recommendations for delivery of high-risk concentrations. So the standardization piece of this is not just the concentration, but how it gets to the care provider. So specifically, like ketamine, the high-dose ketamine, which is used for IM injection, you don't necessarily want that at the bedside as easily. Insulin was another drug that was brought up. So identifying those high-risk concentrations in that standardization and calling them out as ones that need specific recommendations about how the drug gets to the bedside to try to prevent patient injuries. The next category was with regard to labeling, and this was a really interesting discussion. I learned a lot in this discussion, and it seems clear that there's an intellectual property void right now around standardization of vials and syringe labeling. The manufacturers would welcome it. They don't have the ability to create it. The FDA is not going to create it. There really isn't a group that's making that happen right now. So our recommendation was that APSF should create a request for proposals to develop standardized labeling of vials and syringes with the goal of providing grant support to a team of graphic designers, human factors experts, and clinicians to solve this problem. And so I think that that's really a void which APSF can help to work to fill, and maybe a grant program is a way to do that and help out the organizations that really need that help. And then with regard to administration, there's a little bit of overlap from the previous group, I think, in this regard. But I think what we came down to is that in our conversation, we recognize that there's a technology problem here. Barcoding is really imperfect. Andy spoke to some of their experience and the problems they've had, or the gaps in barcoding. It gets us part of the way, not all of the way. So we didn't really want to recommend a particular technology solution, but we did feel that every medication administered during anesthesia care should be independently verified. And then whenever possible came out of our conversation about what about a trauma or a situation where you really don't have the bandwidth to verify. But anyway, verified to conform with the 5 rights of medication administration: right patient, right drug, right dose, right route, and right time. See if I have any other. Another important thing that came out in that conversation that we didn't have a specific recommendation for, but was mentioned previously also, is the notion of documenting first. So how important is that as a way to create safety in the medication administration process? And is there a workflow that we can promote in that regard? So we didn't have a specific recommendation around that. So I hope I've captured the essence of our conversation. It was a little bit quick back there to write this up. But if any of the group has anything else to add, there were a lot of things we talked about, but I think what was great was the level of engagement and enthusiasm for the topics. And so I think there's an energy level there to try to solve these. But yeah, Omi. Correct, right, yeah. Yeah, that's a great point. So once we have this standardized labeling approach, it's something that can appear on the infusion pumps, it can appear on the EMR and really resonate throughout the whole medication administration process. Yeah, thank you for that. That's great. Yeah.
So question for you, Jeff, thanks, about the standard concentrations, which I completely agree with. In the intensive care unit, we deal with fluid overload a lot, and not uncommonly want to concentrate medications or change the formulation, take it out of D5, put it in normal saline, or vice versa. Do you have any thoughts about guidelines for deviating from standard concentration? So if you must deviate, then do this.
So I actually am going to call in someone to help with that. Deb Wagner, I think, can probably comment on their Michigan experience. And maybe you can comment as well. But the other caveat to that is we did have a conversation around pediatric patients and how do we deal with the needs of pediatric patients. And do you need a separate product line for pediatric patients, for example, to recognize their concentration needs? But please, comments.
So I'll comment of what we're doing on the national level for the Standardized for Safety. The first premise was use a commercially available product whenever possible, but also try to limit to 1 concentration whenever possible. Out of our 32 drugs, I would say the majority of them have probably 2 concentrations. The reason being for exactly that. We need something that is a little less concentrated versus more concentrated. For instance, phenylephrine, there is a standard dose, and then there is a high concentrated phenylephrine. It's back to, though, what you use at your institution. If you are not a large trauma center or a cardiac surgery center, you don't need high concentration phenylephrine. So we did give choices on the chart that we made. In regards to pediatrics, we took the adult concentrations and then worked backwards and then looked at flow rates. So we actually have Vinay as a physician, a pediatric physician out of Phoenix, that he has a calculator, and then we looked at when we get down to so many mLs per hour, and then we would change to a different concentration. So that pediatric list will be coming probably out in the next 3 weeks, but there is flexibility. So this morning we heard in the presentation, we like standardization, but we also need some flexibility. There is some flexibility in those concentrations. So a very few of them really have, the 1 concentration. And there, I will say, there are 2 drugs on the list that I'll just prepare you for right now, of norepinephrine and hydromorphone, where there are 3 concentrations. However, when we went down to the PEDS concentrations, we did use those same concentrations and tried to stay consistent until we moved to a next concentration. Mm-hmm. So does that answer the question?
Yeah.
Good.
Yeah, I wonder a little bit if it's the 80-20 rule too right now, so that, if we can standardize something and get a good bit of the way there, recognizing that there's still going to have to be a little bit of leeway. But. Jerry.
Jeff, one caution about documentation before administration. There's some legal issues there. Normally, you can't document something you haven't done, but you can write an order for something and then check off that it was done, and it may work just the same way, but from a legal standpoint, you probably need to be sure that this is run by folks who understand that particular parameter.
It's a really interesting notion, you know, that does the documentation thing get labeled as an order when you barcode it and everything else, and then it sits in a list, and then later on you go by and you check it off, and does that make it an easier workflow if you do, and then satisfy the legal requirements?
Yeah, I mean, and one of the references I'm making is to something a little bit different, which was our desire to have all of our post-op orders actually written before the patient enters the recovery room. Joint Commission was terribly concerned that we would be ordering things without actually having an interaction with the staff in the recovery room. Actually, the rationale wasn't quite that rationale, but that was the idea.
Yeah, I'm actually being evaluated on a quality metric. If I don't put my orders in before I go to the recovery room, I'm actually dinged right now. So pharmacy has time to validate them before the nurses get it. So works both ways. But other comments, questions? Okay, thank you. Mark, back to you.
Okay. Folks, it's been terrific having you here, and the passion in the room about this, it's a great thing to be passionate about. It's a noble cause of patient safety. So a couple things, just a couple thoughts crossed my mind. Collaboration is going to be the key here. We're going to have to collaborate with a lot of groups. So Pasco, you're on my speed dial, okay? And those type of things. So the collaborations are going to be really, really important. Chris Waking, you're on speed dial. Lynn Reed, you're on speed. All you guys. A lot of you folks will be. Specifically for these recommendations, I think what we'll do is we'll have an APSF Board of Directors subset, a small work group, basically work with our folks that brought these recommendations together and pulled them together, make sure we fully understand what they are, probably have to do a little wordsmithing or editing to make sure it's clear, so that when the recommendations come out, there's a lot of clarity on what that is, and it's not vague. It's got to be specific, and most of these are almost there, but might need a little wordsmithing on that. So we'll get that done in the next month or so. And then, so we'll have final recommendations, and we'll get published. We'll put them on the website. We'll get them out in the APSF newsletter February, Steve? Yep. Yeah, Steve's all ready for it. November deadline, yeah, thanks a lot. And so we'll get that going. We'll send those out to all you folks so you see what they are also, because I want you to be the first to get those because you played such a big role in putting them together. Specifically for the meeting, we'll be sending out a post-meeting survey. Again, not next week because I'm not going to be around next week. But we'll get so just make sure that from the conference standpoint, it went fine for you folks. I also will be looking for specific individuals who'd like to volunteer to be on some of these work groups. I mentioned we're going to put some small teams, maybe teams of, I'll have to think about it, 8 or 10. We pull them into Chicago for one day. So unless you're from the West Coast, you can probably fly up, make it for a 10 o'clock start at the Chicago O'Hare Hilton. We meet right in the Hilton. At 3 o'clock, you're done. You go get in your plane, you get home same day. So we'll cover the cost of doing that. But I think we need some volunteers on each of these to take these recommendations and really think through how do those get done so that we know what to do next. And I think basically we will be the conveners, the advocates that push all the different organizations we need to help move these forward. The end result we all want is to get some of these things over the goal line and change patient outcomes. And I think that's really important. If you like the meeting in any way, Amy, tell me what folks have to do. Come up here and, yeah. Amy Pearson is kind of our lead director, tweeter, social media person with Marjorie Siegler and Emily. I don't know if Marjorie and Emily are in here. Yep, there's Emily. But tell them what you're interested in.
Okay, all right.
She's never shy.
So can Sarah Moser raise her hand? She's our philanthropy guru. And I just want to tell you guys that we so far have raised $2,000 just through the dip jar. And I hope that you guys, yeah. So I hope that you guys consider the fact that this is a free conference and we had some delicious food over the last few days for free. So if you feel it in your heart to donate to APSF and drive us up to $3,000, $5,000, that would be a great advance for patient safety. Thanks.
Wow, I didn't know that's what you were going to do. Oh, thank you. Thanks, Amy. Did you want them to also tweet about the meeting? If, yeah. Here, come back here. I'm going to make her a fundraiser also. Sarah, you may have a partner.
So tweeting about the meeting, basically our hashtag is hashtag APSF 2018. And all you have to do is search that on Twitter or on Facebook, and you can retweet, share, remix, and comment on anything you want. And so far, we've probably made about 300,000 impressions just from this 150-person conference or so. So that's pretty huge, and we're engaging a way bigger audience than just the people here. So you're making an impact.
Yep, great. Thank you, Amy. And really, the communication is such an important part of this. You know, we've got at least 70,000 active anesthesia professionals working in the United States. And worldwide, it's 350,000. There's no reason we can't use our social media to jump out there. So if you have 5 followers or if you have 5,000 followers, if you wouldn't mind tweeting something out there and retweeting some of the things that have already been out, we'd love that too, because we want to reach out to all these folks. Our Facebook is another way we'll be doing that. So anyhow, thank you all for coming. We've got the bus is picking people up. I'm going to leave at 11:45. Are there any other details? Anybody have any questions? Yes, Deb. You can come up here, Deb. Be shorter.
So I just wanted to say thank you, one, for having this meeting and inviting me. The collaboration here has been fantastic, and we'll keep doing the Standardized for Safety initiative and move that through over the next year. The other part is that you are not alone. So the drug shortages, we really heard everyone is affected. Please work with your pharmacies at home, but if for some reason, if they can't get what you need or whatever, tap into us. Like my organization, we are a national organization. We have Aaron that's full-time at Utah. We have Mike who's full-time at my organization. You are not alone. We had Michigan who actually took a picture of a vial and sent it to us of a 2 ml concentrated KCl vial. That instantly prompted a call from me into Mike Cohen, and we put out an alert. Like, you can make a difference. So please feel in like your daily lives of like this is just overwhelming for you. Push that back on me. Push that back on our organization, because we can help you. So thanks.
Wow, thank you. Okay, well, folks, we're ahead of schedule 15 minutes. Thank you all for coming.